Okay, hello everybody and welcome to this session. So this is a wrap up of the sessions which we just did. This is about left main and multivessel disease. I'm Sripal, Bangalore from NYU School of Medicine. My co-moderator is Dr. S.J. Park, and we have a distinguished panel here. Maybe I want to kick off this. I mean, I think the left main session was fantastic. One of the things that I took home was one of the concepts that was discussed, that the majority of patients, are eligible for PCI. Now the question is, who are the patients we should really be considering for CABG? Maybe Dr. Park, I mean, if you can tell us your opinion on how you would choose patients to refer for CABG.
Left main disease 가장 concern is a large change during the last 20 years. So current guidelines still, high anatomic complexity and high syntax score should be bypass surgery would be good, and the low torsile and the intermediate torsile syntax score or low anatomic complexity for those particular patient region subset class 2A, guideline indication. So practical point of view. So if you look at the high syntax score concern, that is mainly related with the three vessel disease, even more than 32, combined three vessel disease. And so simply the epicardial artery multivessel disease would be favorable anatomy for PCI. Good, morphological concern for PCI. We can do the PCI, stand for that. And any bifurcation region, ostial shaft bifurcation region would be, I think it's good candidate for stent procedure, single stent crossover, two stent technique. And so in the practical point of view, we have to concern about the more epicardial artery disease. And second one, most important thing is LV functions. If LV function less than 40 something, so we have to be careful, right? Anyway, surgery versus multivessel, unfavorable anatomy, we have to consider bypass surgery those, right?
Yeah, just to tag along those, Shamir, I'm curious, your practice in Canada, so you have a patient left main disease with low intermediate syntax score. Are you routinely taking these patients off the table and doing a heart team discussion, or only are you reserving that to high syntax left main multivessel disease patients?
We certainly have a discussion with every patient before we go ahead and do left main PCI. We have a heart team. It's discussed with the referring cardiologist as well as with the surgeon and the patient. The patient has an important say in these matters. We tend to lean towards CABG if there is a lot of diffuse disease, but ultimately we ask the one question, the benefit of CABG is really related to the lima. So in that particular case, is a lima feasible? Does it have, will it have good runoff, good long-term patency? Those sorts of questions, practical issues like Professor Park was alluding to. And of course, the patient has an important say in that as well. So we take all of that into consideration before deciding. So there's no automatic referral for CABG. It's done on a case-by-case basis and based on the randomized trials that we have available and the patient preferences.
So based on what you're saying, there is no ad hoc left main PCI. Are all patients taken off the table, or is this discussion?
Well, we do ad hoc left main PCI if there's a STEMI, for example.
Okay.
So in those cases, we do. Sometimes we'll balloon the left main open and send the patient for CABG, but often these patients are very sick. They've had a lot of damage to their left ventricle, and we have to just treat the left main properly, even if it's in an acute setting.
Yeah, and I'm curious, your practice in terms of left main disease. So same patient, low or intermediate syntax score, left main disease. Are you routinely taking them off for heart team discussion, or you think that is under the purview of PCI, you can just go ahead and PCI those patients?
So if the patient is stable, then indeed we take him off the table, discuss with the patient, discuss with our colleagues from the surgical department. If we have a patient with an acute coronary syndrome and we have a clearly identifiable culprit lesion that is easily doable, then we treat this lesion and then discuss afterwards with our colleagues. and we have a patient in unstable conditions, then we discuss directly in the cath lab with the surgeons in place.
And finally, the same question for you. So, in your practice, are you taking them off?
Yes,
Would you do ad hoc PCI as a low anatomic complexity, and the guidelines are saying it's a class 2A to go ahead with PCI?
Yes, I'm working for the left main center, the SJ, working with SJ. So I totally agree with the SJ's opinion that the low intermediate risk, the left main disease would be the focal left main disease, not related with the epicardial coronary artery disease. Then the left main PCI is the relatively easier than non-left main diffuse disease. So if operators are the experienced the operator for left main PCI, so I don't have any hesitation to treat the patient by PCI. I have another different idea that the left main disease, sometimes I refer to the bypass surgery. If a bypass surgery failed, left main patient critically have a problem because it's different from the multivessel disease. Multivessel disease, if a failed bypass surgery, patient can survive. But the left main disease failed bypass surgery, the patient long-term prognosis would be worse than multivessel disease. So I prefer the left main PCI instead of transferring patient to the bypass surgery if the treatment is feasible by PCI.
What about Dr. Bangalore in United States? Same patient group of patients. What would you?
Yeah, no, I think that's a great question. So I would say it's actually a combination of everything that was discussed. If it is urgent and emergent, we'll go ahead with ad hoc PCI, whatever is needed for the patient. I must say though, if it is low syntax, if it is ostial or body left main with no bifurcation, I generally tend to speak to the patient on the table and not routinely take them off the table to make that discussion. Because most of the times we would have spoken to them earlier to assess their DAP compliance, etc. So in only those, if it is low syntax, low complexity, we just go ahead and do ad hoc PCI as long as there are no red flags. But if it is anything, intermediate high syntax, and specifically if it is high syntax, we take them off, get surgical consult. But of course, one of the challenges we have is a lot of surgical turndowns because most of our patients have a lot of comorbidities. I know we debate about left main PCI cabbage, but in the reality, there are a lot of these patients where they are just not surgical candidates and they get turned down.
So, right, you have 10, left main disease patients, Anyways, how many patients do you approach the PCI? What percent?
I would say that 60% number that you were saying is, I think, more appropriate. Interestingly, the 40% we refer for surgery, I would say nearly 50% of those get turned down by surgery because they just have too many comorbidities. Whether it's end-stage disease, too low EF, they have vascular disease, etc. The practice I have is it's more of we see mainly ACS patients, so they're much sicker and
Okay.
Yeah, I think maybe moving on, if you move to diabetes and multivessel disease, I think that's another area where heart team discussion. There's a lot of data for cabbage and stuff. I'm curious. Let's start with Dr. Park about Freedom trial and does it apply now? What do we do because the guidelines are looking at Freedom and giving a class 1 indication for cabbage. Should we be following that? What's in the pipeline?
Right. Anyway, personally, I think the ischemia study is a turning point in our concept and practice concern. However, PCI versus bypass surgery for diabetic patients, especially for the really old data, very 2D study, Freedom, even syntax subgroup study, all the study they use the taxes, even bare metal stent, something like that. There's no idea about physiology and the imaging concern. And so Dr. TW, our faculty show that defined DM studies. The reason why we organizing. Some diabetic patients, not too much compromised LV function and multivessel disease. So why not? We're going to do, very smart, contemporary PCI versus, bypass surgery. And so personally, I think we need more detailed data and more answer in the future. So.
Yeah. No, I completely agree. I think we need more data. And just moving on to STEMI and multivessel disease, Shamir, you've been instrumental in changing the guidelines around the world. Your quick thoughts on your practical approach. You have a patient, it's middle of the day, patient has multivessel disease, you fix the culprit. Are you going to tackle the non-culprit at the same time, stage them? Would that be different if it is in the middle of the night?
Yeah, I mean, it all depends on how stable the patient is. So certainly, if it's a non-STEMI, we often will do it all at the same time. There's no issue in a non-STEMI. So when we do the non-culprit lesion, we like to use imaging. Sometimes they're complex. There's calcium. It's a bifurcation lesion. You have to use a two-stent strategy. So if you're doing somebody who's just had, a large infarction, let's say they've had a large inferior infarction, they have RV involvement, they're hypotensive, and your non-culprit lesion is an LAD diagonal bifurcation that's calcified. I mean, it makes no sense to do that at the same time, right? There are some people who will say they do it, and that's fine. But if you're going to extend the time on the table for a STEMI patient by another hour, hour and a half, doing imaging, giving extra dye, potential for complications, side branch occlusion, et cetera, it doesn't make any sense. Usually what we'll do with that patient is we will admit the patient, we'll open the culprit, restore flow, and bring the patient back the next day or the day after, and we'll do the non-culprit lesion at that time. I don't think we really lose anything by doing it that way.
Yeah. And I'm curious, in your practice, I mean, the same question, you have a patient with STEMI multivessel disease, you fix the culprit, what do you do for non-culprit? Would there be any proportion of patients where you would say, let's get it done now, discharge the patient so that,
It depends on how easy you can treat the culprit lesion. If it's one balloon dilatation, we are doing DCB in this situation frequently, and I have another lesion which is easy reachable, then we'll do this also. But as you said, if you have more complex additional non-culprit lesions, then our strategy is also to do a staged procedure. We are doing this typically after 5 to 6 weeks. This is due to the reimbursement system we have in Germany. Otherwise, we will do it earlier, of course.
and your practice?
Usually, I apply different strategy to the non-STEMI and STEMI. So sometimes some trials included the STEMI and non-STEMI patient both. But I believe that we have two different strategy to the STEMI and non-STEMI. For STEMI patient, I prefer the culprit lesion only, and re-evaluation non-culprit lesion by non-linear functional study, something like that. My small experience that the most patient with multivessel disease in STEMI patient don't complain chest pain after culprit lesion intervention. And during the follow, patient complain chest pain, I will do something more. For non-STEMI, compared with the STEMI, non-STEMI patient, the coronary artery disease, I think more complex. So sometimes, which is culprit? Definition of culprit is very difficult in non-STEMI patient. So in such a situation, I think a full revascularization will be the very important for such a condition, and not with the PCI, but we have to consider the bypass surgery in this situation.
Yeah, I think, my practice is somewhat similar in the sense that I agree complexity matters. One of the lesion subset, if it is simple, is if the culprit is LAD and the lesion is circumflex, I don't have to change my guide. Those may be one of those where if the lesion is simple, you just get it done. So, but again, depends on the time of the day, how much contrast is used, and a lot of other factors. Maybe let's switch gears for a second and talk about imaging versus physiology. And I think, kind of a hot topic everywhere. Imaging versus physiology. Shamir, I'm curious, your current practice in an ACS setting, are you using imaging? Are you using physiology, or are you using both in your patients? For
We're using
ACS
both.
patients?
We use both in our patients. Right now, most of our multivessel disease patients are going into complete 2, so they have imaging done, or they have physiology done, and then they have imaging done if they're randomized to that arm. If they're randomized to the angiography-guided arm, they receive angiography-guided PCI, but it's image guided. So, we use both, is the short answer. Can you get away with a physiology-guided strategy for a non-culprit lesion? And how does it compare to an angiography-guided strategy? We don't know the answer yet. I suspect that it may be non-inferior, and you actually can substantially cut down on the number of unnecessary PCIs. We all want to do that. Even though we're interventional cardiologists, nobody wants to put a stent in if a patient doesn't need it, right? We don't want to do that. We want to do the right thing. And so if we can do that, and we have a non-inferior result, I think that's good for the patient. It's good for the healthcare system. But we just don't know the answer yet. It may be, future events may be predicated more on the plaque vulnerability, or the plaque biologic characteristics. That may be what's pushing future events. What we do know is that the two are not separated. So the more severe a lesion you have, the more likely that lesion is to contain a vulnerable plaque. So if you have an 80% lesion, it's more likely to have a vulnerable plaque than if you have a 30% lesion. So we know that it's not separated. So, we'll see in complete 2.
How would you define the vulnerable plaque? By imaging?
Yeah, we're using imaging. We're looking at we're mainly OCT imaging, and we're looking at a lot of different parameters of plaque vulnerability. We have an OCT core lab that's collecting all of the images globally. They're reviewing it in a standardized way.
So the acute coronary syndrome actually is basically systemic vulnerability
Yes,
also, right?
correct.
So
Yes.
I just curious about non-culprit stent procedures compared with the stable coronary artery, for example, ischemia study. Is there any difference peri-procedural, any complications, something like the slow flow? What's the difference?
ACS patients generally have higher complication rate than stable CAD. Having said that, there are other, if you look, for example, at the Syntax trial, which was mostly stable, almost all stable CAD, the disease is just horrific, right? They have calcified disease, they have diffuse disease, there's left main disease. In a STEMI multivessel disease population, first of all, the average age is 20 years lower. So STEMI multivessel disease is largely a young person's disease. The mean age is low 60s versus stable multivessel CAD, the mean age is 70, 80 years of age. It's much more diffuse, it's much more complex, and it's much more calcified. So that adds to the procedural risk in the stable disease population.
If you some data about imaging data, right? We will learn from our imaging study, prevent study. Even negative FFR, stable angina, among them around 40% of lesion would be vulnerable characteristics. So you can tell us some how much the incidence of a vulnerable plaque in acute coronary syndrome would be a little bit different?
Yes, it's very different. It's in acute coronary syndromes. 50% of patients with obstructive non-culprit lesion disease. So they have obstructive disease, meaning visual 70%, 50% will have a vulnerable plaque, as traditionally defined as a TICFA. How we define TICFA on OCT imaging. So 1 in 2.
50%.
50%, yes.
Right. Actually, absolute numbers our data is from registry data. Exact number is 46% something, right?
That's right.
It's not too big difference in total, right?
Yeah, very similar. And there are multiple studies that have shown that, both invasive, but also the non-invasive, the CT imaging studies have shown that it's about 50% in the non-culprit lesions.
Yeah, I'm curious, going back to the same question, in your ACS patients, maybe we can divide it as STEMI versus NSTEMI. Are you using physiology, are you using intravascular imaging, or both in most of your patients?
So the official answer is, of course, you should use imaging, but we have to realize that in Europe, for example, less than 15% of all procedures are supported by intravascular imaging. That's the reality in Europe. From a practical standpoint, in STEMI patients, flow is the flow you achieve is the first important predictor. And the next question is what you said. You have a large number of vulnerable plaques in the non-culprit lesions. What to do with those lesions? If they are non-obstructing, is it better to do medical treatment or stand it or do some other kind of local drug delivery? I think that's an open question and very important for future trials, I think.
And you?
In my practice, I'm using both FFR and imaging, but a different purpose. The imaging use the optimizing the stent result, and FFR use the to treat or not to treat. But nowadays, one sector is invaded the other sectors. So I think even though I believe that I apply for the complex coronary artery disease, I think stent optimization is more important than to treat or not to treat decision. So I favor the IVUS guidance is more important. But simple disease, stable simple disease, not to do means that nothing to do is associated with a better outcome. So I'd like to use the FFR first.
Yeah, I think my practice has evolved in a way. I moved away from using physiology in all patients with ACS and moved to intravascular imaging. Mm-hmm. And I think that's one of the main reasons COMPLETE 2 and other trials are so very important. Mm-hmm. And I think we'll learn more and more about physiology versus intravascular imaging, or do we have to go to a phase where we need combo? Because it doesn't make sense to have different wires and catheters, and now there are ways of trying to see if we can get physiology by using an OCT catheter, and will that be helpful? But I think this was fascinating. I know the time is up, and I think we had a lot of moving parts in management of patients with left main and multivessel disease, a lot of moving parts about the intravascular imaging and physiology. And thanks for everybody. Thanks for tuning in.